Another little piece of data. Anybody familiar with the Harvard 75-year happiness study? If you're not looked that up, guess what the number one indicator of happiness is? It's not money, it's not where you live, it's not what you drive. Social connections. Relationship is the number one indicator of happiness. And this community that Ronald McDonald House has built builds relationship and connection.
So my name's Lloyd, Tani. I'm one of the pediatric cardiologists here and have been here at the University of Utah and Primary Children's since 1989. During that time, we've experienced growth in our division from 5 cardiologists to now in the mid-30s. And during that time, there's been evolution of our program from one providing local care to one now providing care for one of the largest, if not the largest, geographic referral areas in the country. I had the privilege of serving as the division chief for pediatric cardiology from 2007 to 2019, and then served as the co-director of the Heart Center here when we embarked on that back in 2011. And then really importantly, I was very honored to serve on the board of the Utah chapter of the Ronald McDonald House Charities from 2017 until last year. Next slide, please. So just to give you a little bit of background on the patient population that I serve, congenital heart disease is the most common birth defect, affects just below 1% of kids. About 1/3 of those kids require intervention as a young child, a neonate or infant. There have been major advances in the care of these patients so that back in the 90s, many patients with the most severe disease would die. Now the overwhelming majority survive, and the shift has gone from survival to how are they doing. And Ronald McDonald House plays a huge role in that, as we'll talk about. These advancements have been due to improved surgery, catheter-based interventions, and then advanced heart failure management, including mechanical assist and heart transplant. Next slide. So I'm not going to go through all of these, but this just gives you a flavor of the number of different subspecialties within cardiology that we see in the outpatient setting there on the left, and in the inpatient setting. I'm sorry to turn my back to you folks over here. On the right, on the inpatient level, everything from general care to surgery to advanced heart failure to mechanical circulatory assist, and there's various forms of specialized testing. Next slide, please. So back before 2011, different entities would touch kids with heart disease in terms of care: cardiology, surgery, anesthesia, nursing, and critical care. And all of those entities would do their best to take care of the patients in their own silo, but it was very siloed. So in 2011, next slide, we moved to a heart center type concept with the patient centered approach, collaborating and looking for ways that we could work together between these different entities, again, focused on the patient in terms of care. Next slide, please. So through this collaborative model, there was a focus on care and outcomes, patient safety, trying to control costs, care for the patient and family, and then communicating better with referring providers. Next slide, please. So this slide shows you a map of Utah, and the reason for showing this is because of how our care model has evolved over time, and this is particularly important given Ronald McDonald House's role. So again, we used to really serve local populations, and now we see patients from all up and down the state. We have clinics up in Logan all the way to St. George. We have clinics up into southeast Idaho, Pocatello and Idaho Falls. We have a regular clinic up in Alaska. We get patients from Billings, Montana, Boise, Idaho, and Nevada. So patients coming from long distance and then needing support. Next slide, please. So as care has evolved in the Heart Center, there's now bedside rounding that includes family and nursing, increased social work support in the Heart Center with now, I think, a total of 5 FTEs committed, personnel dedicated to helping patients from a distance navigate our system, so so-called patient navigators, helping patients interface and then find their way once they get here. Child life specialists have been critically important in both inpatient and outpatient settings. There's a parent organization called Intermountain Healing Hearts, and then we participate nationally in a quality improvement collaborative that includes parent representation from our population. Next slide, please. So the last slide is, so with this evolution have come challenges and opportunities, and Ronald McDonald House, again, has been very, very central in addressing many of these. So as in many parts of medicine, there's been a shift to sicker and sicker patients being now outpatients. There's been an evolution of inpatient care to sicker patients as well, with now multiple or longer lengths of stay, providing a need for families. With a larger referral base, challenges of coordination of care, access, housing, support. Maintaining a patient and family-centered focus has continued to be an important challenge. Engaging parents in shared decision-making wherever possible. Enhancing the child's and family's hospital experience. Allowing, obviously, parents who live far from the hospital to stay close to and involved in their child's care. Improving family coping and cohesion, and supporting parents and families through very stressful, anxiety-provoking, and challenging time. So I'll stop there and then pass this on to our other panelists and then look forward to questions or discussion.
Thank you. Dr. Bernstein.
Hi, good morning. I'm Sarah Bernstein. I'm a neonatologist at the University of Utah. I also frequently staff the NICU at Primary Children's and at Intermountain Health. My research interests are in communication, shared decision-making for critically ill infants. I'm particularly interested in how a family's history and values and experiences prior to coming to the hospital actually directly impact the decisions that they make for their children and their long-term health outcomes. I'm actually going to tell you just a little bit about me, a little more about me personally, and why this topic is so important to me. I grew up in Chattanooga, Tennessee, pretty sheltered, and didn't have a lot of exposure to diversity. And I went to college and undergrad in upstate New York. Wonderful school, not known for its diversity either. I then did medical school at Emory in Atlanta, and I felt like I graduated with a really strong background in medical knowledge and best practices and evidence-based medicine and counseling in general. But it wasn't until I did residency at the University of Illinois in Chicago that I really was exposed to poverty within the U.S. for the first time. Next slide, please. So I remember early on in my intern year, I had a mom who was just super apologetic because she was 15 minutes late. And she said something like, "I'm so sorry it took us 3 hours to get here." And I remember thinking, like, this is Chicago. How could it possibly have taken 3 hours to get here? And I soon learned that even in a city where there were a lot of hospitals and physicians and public transportation, that often places weren't well connected. And so families were taking 3 buses to come see us in clinic. And what a huge commitment on their part, and also a burden that even getting access to care was for them. And so I had these families that, were just amazing and really involved in their children's care. And sort of the second part of this is within this patient population, there was a lot of obesity and hypertension and early diabetes, where we were diagnosing type 2 diabetes in kids as young as 8, 9, 10 years old. And I remember these families were really engaged, and then we would get to the counseling portion and they had like printouts and here's how the growth chart is and here's stuff from the AAP, and just kind of being met with blank faces, and everyone was super polite, and but there wasn't really a lot of back and forth, and I knew I was missing something, but I really wasn't sure what it was. And luckily for me and for the patients that I've seen since then, part of our residency training was spending a month with social workers and early intervention, actually going to these families' homes. And I remember really vividly that first drive out there, you know, we're almost an hour away from the hospital, and I'm looking around and there's fewer and fewer stores and shops and just resources in general. And so we're about to get to a family's home, and the social worker points out the gas station. She said, so that's where they get their groceries. And I was just like dumbstruck, because I was like, that's not a grocery store. Like, that's a gas station, right? And it immediately dawned on me, you know, how tone deaf a lot of my counseling had been, and that it wasn't only not helpful, it was actually potentially harmful, because I was counseling these families to do things that were literally impossible for them in their situation. And so I felt like I was just setting them up for failure. And that really, next slide, please. That changed the way in which I thought about patients and families and counseling in a really impactful way, because I wasn't making up this counseling, right? This all came from best practices and guidelines. And so I stopped asking myself, what are best practices? And I started asking, what are the best practices for this child who's part of this family, who lives in this community, who has these resources and this social support? Because that's what we're really doing. And when we're talking about goals and how to accomplish those, like, we need to be thinking about all of those things. And so I won't spend too much time on this, but when I say it changed my clinical practice, it really also changed the way in which I communicate with families. And so I start questions much more broadly. You know, tell me about your child. How do you feel like she's doing? What are your hopes? What are your fears? When we get to the stage where we're going to be discharging, you know, what are your goals? What's important to you long term? And then with that, what are the barriers or challenges you might face in accomplishing those goals? And I think that really helps align us in the sense that, like, these are the goals that families have stated are important to them. And then talking about the social stuff in a way that, you know, I'm not asking to pry, but I want to know a lot of families struggle with housing insecurity or food insecurity. And often we can help support you in those things. And we just need to know what they are so we can connect you to the right people. And then that brings it back to you and kind of this teammate mentality, because when I get that information, I have no idea what to do with that. But I know who to contact who can then help. So thank you for inviting me to be here today. I'm really excited to chat with you and to learn from you all.
Thank you. I'm a big believer, people know this about me, I feel like the answer to any sociological question is it depends. And I love that, like, kind of, where are they? Start where they're at. Yeah, thank you. All right, Dr. Bleyle.
Is that an insult to everybody here that's like actually gone through medical school?
No, you are an expert in you.
Hello,
and your
my
family.
name is Dr. Rylie, and all of you are like, she's crazy. Okay, so my name is Rylie. My last name is Bleyle, so you'll probably never forget that. But it's my husband's favorite way to introduce me to people is he always tells them, well, I couldn't marry her because I couldn't do that to her. And then a few weeks into dating, he was like, no, I'm going to have to do it to her. Sorry. Says it in church talks and everything. So it's great. I have a 5.5-year-old named Emmett. And if I was more prepared and not a parent of a medically complex child, I would have a very cute picture of Emmett up here, but I don't. But he's cute. Just trust me. He is turning 6 soon, like I said, and at 2.5 months old, went into liver failure. Our journey kind of started with a fever, and we just kind of thought that he was sick, had a cold, took him into the hospital down at Provo, and because of his age, they had decided to admit him overnight, obviously to get him some IV fluids for the dehydration, break his fever, and they told us we would be out of the hospital in 24 hours, and I'm convinced that doctor jinxed us. So we were admitted to the Utah Valley Peds unit, and after a routine panel of blood work, it came back that Emmett's liver enzymes were the highest that anybody had seen at that hospital, and we were immediately transferred to Primary Children's, where we spent 3 months in the Pediatric intensive care unit trying to figure out what was going on with our son. The more we looked into Emmett's health, the more we found all these problems, and nobody was finding any answers to these problems, and we ended up with this long list of, you know, liver failure and thyroid failure and seizures and developmental delays and swallowing problems, and just the list went on, and eventually we ended with a genetic diagnosis and it's called phosphomanubutase 2 congenital disorder of glycosylation, or PMM2 CDG for short. Emmett was 3.5 months old when they suspected it, and when they finally received his whole genome sequencing, blood panel that came back diagnosing him, they walked into our room. I was actually alone. Emmett was asleep, and there was about, I swear, 40 people. I know that sounds like an exaggeration, but like people were piling into our room continually, and they told me, you're going to want to sit down. And they gave me a piece of paper that had 3 sentences on it, and it basically said that the blood work had confirmed a genetic diagnosis of PMM2 CDG. We learned that my husband and I both carry a random same mutated gene, and that Emmett would probably not live more than 6 more months. And that's how the conversation ended. And these people left the room. The nurse came in and said they were going to discharge us home so that we could spend, our time with Em. And that was that. So it kind of kicked off a year of a lot of questions. We had no answers. He was the first diagnosed in the state of Utah. Our geneticist had never seen it before. They, most residents that we had run into and people that we had worked with had never heard of it. And here we are, 5 years later. So we've been on a roller coaster ride. Emmett struggles with a lot of things. His body does not cooperate as much as his mind does. We, average about 2 hospital stays a month. Those are a week or longer. That's kind of our baseline. Our longest hospital stay was in 2019, right before COVID hit, and we were at Primary Children's for 11 months. So I'm very experienced in the hospital world. I'm not officially a doctor yet. Just kidding. That's not happening. But Katie laughs because she knows I do not have the drive for that right now. We're going day by day here, people. No, but, we have experience immensely with Ronald McDonald. Part of 2019, we were actually life-flighted out of state to Philadelphia, where we were transferred to CHOP, the Children's Hospital in Philly. And that decision was solely based on the fact that there was a Ronald McDonald House 1.1 miles away that we could walk to and from. We've stayed in Ronald McDonald houses in LA. We've stayed at the Ronald McDonald House just recently in Minnesota. So we have extensive hospital experience, medically complex experience, and Ronald McDonald experience. So I am so excited to be here. This is one of my passions. I will talk about Ronald McDonald till I'm blue in the face, until everybody on this planet knows their resources and, the things that they have to offer. So I'm excited.
Thank you.
Rylie, it is a privilege to go after you because I, in my career, have been coached by family advocates with lived experience. And some of the best knowledge and training I have received have been from people like you. So I do not need to call you doctor. What I need you to call you is a family member. And I have great respect for that. My name is Dinah Weldon. I am the director at Primary Children's Hospital Center for Safe and Healthy Families. A little bit of my journey to being here was I spent 16 years, and I know the cameras here, and I like people more than I do cameras, so I'm going to move a little bit, and I'm sorry. As a matter of fact, if I had my choice, I'd be right behind the pillar, just so you know. I spent 16 years working in inner city Los Angeles, and that means I had an opportunity to work with such a wide range of wonderful children and get to know their environments and their families. And having a chance to work throughout my career with children with mental health care needs has been an honor to share some of their journey and help them in their journey and help them in their healing. After that opportunity, I had a chance to come to the state of Utah, and my beloved director of the Division of Substance Abuse and Mental Health is sitting back here in the corner, Doug Thomas, and my team up here. I will introduce you afterwards because I was telling him how wonderful you are. And in that role, I had an opportunity to be the federally designated Children's Mental Health Director for the state of Utah. And Nicole, you talked about getting to do systems work. That I was used to direct one-on-one, but getting to step back and do systems work was a privilege. And that's where my education from family advocates came. In fact, I've been gone now. Primary recruited me a little over 6 years ago. And I called one of them yesterday, and I'm like, a couple days ago. I did not do this at the last minute, I promise. And she gave me a couple quotes, and they align so close with what Nicole had identified. Oh, you should also know I'm visually, diverse. Okay. So her name is Tracy Tabbitt. If any of you have ever heard of her, she's brilliant and a force of nature. And I see that in you too. So family voice is when there is a two-way communication and parents are given a voice and input in decision about their child or their youth. Then she went on to do more of even broader, being able to influence change. Family voices are key when talking about issues surrounding children's mental health or when trying to improve systems, because children live in families. So only family members truly know if a service or support is effective and whether it will work in their home. And so Dr. Bernstein, when you were talking about counseling families on things they couldn't relate to, she lives in a part of Utah where there are more sheep than people. And they would counsel her to do things, and some people even told her to move with her child's needs. And she's like, but I have 7 other children and this is our home. So I love that we are having this conference today. I love looking around the room and seeing the people that are here that I feel like we're going to just be talking to the choir, and yet we all get the opportunity to have common language. Here at the Center for Safe and Healthy Families, for those of you who don't know, we are the child abuse assessment and treatment team, but we're also the trauma treatment team. And we have an opportunity. So in this room, I just need to introduce you. We have our fabulous forensic nurse supervisor and 2 of our amazing medical social workers. And I have learned so much from them. And they have gifts of working with families that help families feel heard and safe. And I just bow to the things I have learned from you since I've been here. And so we're going to talk about some of those as we go through and have conversations with you all. There are a couple things that I'm really passionate about. One last story about me. I had an opportunity a year ago to become a refugee foster parent. And I got 2 young men from the Democratic Republic of Congo that I am just gifted to be with. And they are okay being with me because I'm not a great cook, but otherwise we do very well. And one of the things that just recently happened to one of my sons was he was working with a new, I'm going to try not to give enough information. He was working with someone in a professional situation that kept calling him a foster kid. And he is an independent foster kid that had an opportunity to live on his own a long time before he had the opportunity to come to the States. He did not like being labeled. So one of the things that I've learned working with children for many years is person first language. And we all know this, but the new people come in, so we have to keep training them so that we talk about the child and then their diagnosis. They are not their diagnosis. And so being able to not group them in any of those type of things, he wouldn't speak up. And it took a while for me to figure out why this relationship wasn't going well when this person was supporting him. And then I was able to understand and go back and coach the person. He's like, I didn't get that. I'm so sorry. And so now he refers to my son with his name. And when I introduce them, at first it was, I have the privilege of being his foster mom, but now it's, this is my mom and this is my son. And how we use labels and how we use names and how we speak about families, how we speak to families are critical. And so that's one of the things that I hope we can talk about a little bit more today.
Thank you. The importance of language, right? Like you heard Dr. Tani talk about part of cardiology is catheterization. What that means to me versus what that means to him are 2 very different things. So questions, thoughts. If it's all right, I'll kick it off if that's okay. And this question is for You, young lady.
Dang it, I knew it.
I know. So we know, okay, there's a lot of talk about data, and so we know from the data that prolonged hospitalizations cause, right, it's never completely quiet in a hospital, it's never completely dark, it's constant sensory input. And when you're here for 11 months, we know what that does to families, right? Stress, anxiety, depression, PTSD, they call them alarms because they alarm you. And when you're trying to rest, an alarm goes off and it's this, right? So for you in this journey, what has been helpful for you?
So it's interesting that you asked that, Orly, and I swear you read my mind. Jason and I were actually just talking about this. My husband and I were just talking about this yesterday. Emmett was just discharged from Utah Valley after an 8-day hospital stay yesterday morning. And the way that we have it set up right now, because we have a second child now that's 16 months old and neurotypical and crazy, we have to split up. And so we tag team it. Jace will stay in the hospital overnight with Emmett until I can get there in the morning with Brinley, and then Jace will leave and go to work. And so I had asked him, I said, how was the night? He said it was awful. Emmett was on TPN, and this dang pump went off all night. Jace was like, probably every 15 minutes I had to get up and silence the alarm. We were in the corner room by the PICU where we could have all of Emmett's, crash cart supplies outside and all this stuff, and the nurses could not hear us. And so Jace was up all night, silencing that alarm, pushing the call button for the nurse, silencing the alarm, pushing the call button for the nurse. And, I sat down with him afterwards and I said, like, are you okay, dude? Like, you're looking a little rough around the edges. Like, what do you need? And it was interesting to talk with him about it because, if anybody in this room knows my husband, and I guess that's, Ronald McDonald and Orly, but Jace is very, everything is okay. We're okay. We're doing great. We don't need any help. Emmett's great, and I'm looking at him like, dude, we're sitting in a pediatric intensive care unit. Our child has not moved in 4 days. I don't constitute that as okay. That's not, we have very different definitions of okay. But Jace is very, very, very optimistic. And for him to sit down and be like, that was awful. I was like, whoa, and we talked about how Jace is actually, and with permission to share this, I've, since taking care of Emmett, suffered from caregiver depression and anxiety. And you are constantly like, did that pump just go off? And it is 1:30 in the morning and you're awake for the next 30 minutes trying to decide if you're hearing something, and then you can't sleep because then your mind is running and you're saying, well, if the pump is going off, is he having a seizure? And if he has a seizure, where did I put the meds? And if I don't know where the meds are, what do I do? Do I tell Jace to get the meds? Do I run and look for him? And you're just in this whole other realm at that point that you can't dig yourself out of. And Jace sat down and told me yesterday that the last 3 years, the alarms and the noise and the constant input has started to weigh on him. And I said, well, what do you mean? And he said, I'm starting to hear it at work, and I'm starting to hear it while I'm driving, and I'm starting to hear it when my phone goes off. And it's this constant, like Orly said, sensory input. And there's no escaping it when you get home because the machines just follow you home. You don't escape them. And so I don't have an answer to that because it's an ongoing process of self-awareness. You have to sit there and be like, why am I so worked up right now? But it's because the feeding pump has gone off 30 times in the last hour. Constantly air in the line, or that pulse ox is beeping all night, and it triggers this other side of you. And I have not figured out a good way yet on coping with that. And I think it's hard for us parents of medically complex kids because something is always happening. And I don't think people realize it because 99% of the time, if you ask me how I'm doing, I'm going to tell you I'm doing good. But I am tired as all get out. Can I say crap? Can I say tired as crap? I'm tired as crap, you guys, okay? Carrie's nodding. I'm good. But, but I'm not going to give that to you in a casual conversation. I'm not going to tell you how many times the pump went off last night. I'm not going to tell you that Jace got an hour and a half of sleep last night. I'm not going to sit there and weigh you down with that. And so it's constant things coming in. Something is constantly happening with Emmett. Something is constantly wrong. We're constantly at a doctor. We're constantly at the hospital. I'm constantly doing tube feeds and medications and, port supplies and infusions and everything. And so it's hard to give you an answer because there's never a break to really process anything. And I think I'm still processing stuff from 2017 when he was born. I haven't even hit, 2019 when we were in the hospital forever, let alone when COVID started. We're 5 years behind on that. And so I think any parent of a child like M, or anybody, that has a developmentally delayed child, son or daughter, would tell you that there's not a real answer for that because you're not really processing it in that moment. Does that make sense? Am I just talking crazy right now? All right.
Not at all.
Okay. What you just described is a trauma response, right? And you're having a very natural, and this is for all of us, right? You're having a typical response to an atypical situation. And one of the things that's important that we try and do in our team is to teach families, and I'm saying this and I'm looking at people so much smarter than me, just so you know, it's really intimidating. But we try and help families understand, doing psychoeducation with families and also with all of us for secondary trauma is critical, helping them understand what the symptoms are that they're experiencing of trauma. And, you think trauma and that has to just be something big and over here. No, this is what you're dealing with is traumatic. And some of the, I wish our behavioral health clinic manager was here. She has a slide that shows while in the hospital, the children's trauma response is maybe this big. Those of you on the left side, I apologize. I would jump out of the chair, but it's kind of high and I'm going to trip and it's on camera. Okay, all right. But yeah, thank you. Okay, so I'm going to translate over there. But the parents' response is bigger. And some in oncology, that was specific to oncology. So recognizing that we have additional needs happening during an inpatient stay and during the work that we do with whether it's physical abuse, sexual abuse, neglect, medical child abuse, any of those kinds of things, we try to work to help the family be able to heal and come back together. And then we also have to look at our team and say, wow, that was really heavy for all of us to be dealing with, and medical providers as well. And we have to be mindful of the secondary trauma that it affects with us, and recognize that that's just all natural. We're trained to respond to an alarm because it's an alarm, and then you get it all the time, and that just ramps us up. And so it affects our sleep, it affects our anxiety levels. So all of that is just normal response to an abnormal situation.
I think really quick with that, I think that it's so hard as a parent to answer that question, because in my mind, I look at it and I say, well, that's not as traumatic as what happened 3 months ago. And that was traumatic. You know what I mean? Like, you're constantly downplaying this medical trauma because you're like, well, I mean, Emmett had a really bad seizure and, was unconscious for 4 days, but that wasn't as bad as the one that he had, 4 months ago where we were in the ICU for 6 days. You know, like, you're constantly downplaying this trauma that you experience because so much is always happening.
And it's because you're measuring them against one another.
Yes.
Instead of thinking of it as cumulative.
Right, exactly. And I think for us, specifically, and I say us, in mine and Jace's relationship, it's, it's so hard to recognize the anxiety and the depression and the triggers and things like that because you're just constantly downplaying. You're constantly saying, well, we're okay now, so we should be all good. We're good. We're out of the hospital. Everything's fine. Take a breather. And then all of a sudden, 4 days later, you're like, why am I so mad? Like, why am I so sad right now? And it doesn't hit you because you're constantly saying, well, he's okay now. We're out of the hospital. He's okay. He's home. But Jace and I are not okay. And we can't recognize that sometimes because you're just in caretaker mode. Very interesting. Sorry.
Oh my goodness, Rylie, you are like the reason that we are all so inspired to do this work. Oh my gosh. My question actually is for Dr. Bernstein and Dr. Tani. So I was really struck, Dr. Bernstein, by this experience where you went to someone's home, and that isn't generally the way that medical education works, nor is it the way that we at RMHC, we don't have those opportunities very often either. And so I just wanted to hear a little bit more about that. Like, how do we try to provide more of that kind of training for people in all of our service roles, like all of the people who are trying to help families, And I also just wanted to hear a little bit about what your perspective is in such a sort of elite academic setting, like what the state of family-centered care is here today. That would be helpful.
Yeah. I wish I had a really simple, straightforward answer for you. Go back to, as with everything, it sort of depends, right? But I think part of the reason that was such a key part of my formal training in Chicago was because it was identified as this being a real problem for trainees coming in and really not having any idea about any of the social circumstances that were a very big part of the family's lives in which we were treating. And so I guess I would say step one for sort of identifying and improving medical education is recognizing that these things are important. So I think there's been a lot of growth, and we talk about kind of preaching to the choir in terms of social determinants of health and ACEs, and those being really key to long-term outcomes. I would say, I haven't taken a formal poll personally, but I would say that I think there's really, really strong data to support that, but I don't think that that's fully filtered throughout the medical community. So I think that the people who really are educated and know about this literature, I think is still probably in the minority. And so I think kind of step one is recognizing that all of these things really are impacting not just the acute hospital stay, but also whether or not kids get readmitted, the amount of time that they're in the hospital, their long-term neurodevelopmental outcome, looking to some other countries who have better support. I think a lot about like prenatal care and postpartum care, and whether or not there's maternity leave and paternity leave in these countries. The amount in which the parents are provided in their child's NICU stay and really able to provide the care is very different. And when they look at looking in the same place, parents who are able to be actively involved in changing the diapers and weighing their babies and bathing, their hospital stays are shorter, their bonding is better, the long-term rates of anxiety and depression and PTSD are lower. I think that area is really like a newer kind of emerging data. But that's kind of what everything is suggesting, is that having parents be a part of their child's hospitalization is so important and so key. And I just don't know that we're really there in the US in terms of like having that support from policies and then also within the hospital medical training. So that was kind of a long answer to say, I think we have to identify that this is like a problem and that there are things that we can do to improve these outcomes. And then thinking about like what's missing. And I think, if people have the ability to really interact with and speak to families, and I know we've kind of echoed this, like I think some of the most important lessons that I've learned and things that have impacted my practice have come directly from families and speaking with families and asking, right? I think so often we don't really ask. We come in and we talk about like, this is the diagnosis and here's the treatment and here's the outcomes and this is the average and this is what we expect. And we forget that like for a lot of families, the average or the expectation is irrelevant. Like, talk about my child and the range of expectations for my child and like the things that are important to me, right? Because the data says, well, there's a 90% chance that this child's not going to sit on their own by 2. And you might tell a family that and they're like, who cares? They sit by 3. Who cares? Can they love me, right? And so I think, I kind of got a little bit on a tangent, but hopefully that answered a little bit.
Go ahead, Dr. Tani.
Yeah, so just a brief tangent. When you talk about length of stay and alarms and all of that, there is evidence in our field of congenital heart disease that longer lengths of stay impact neurodevelopmental outcome. So we have evidence that actually that's one of the risk factors for neurodevelopmental delay is being in the hospital longer. Now, obviously, there are multiple factors to that, including the severity of illness of the child and that sort of thing. But length of stay is one of the risk factors for our kids, and so it's not surprising that there would be some impact on parents. We, because of the shift in cardiac care and the success that we've had with children surviving, as I said, there's been a shift to not are they living, but how are they living? And so there's now a formal neurodevelopment clinic for our kids with heart disease who have these risk factors, have had neonatal surgery or long lengths of stay or seizures in the hospital or ECMO or those sorts of things. And it's very interesting, and I have the privilege of being one of the cardiology providers who participates in that clinic. And the shift is there, not how are they doing from a heart standpoint? They have a separate clinic for that. But how are they doing? How is the child doing neurodevelopmentally? What is the family seeing? And we get very different answers when we have that sort of interaction. To get back to our field, I don't think that we're doing a great job at educating our trainees, for instance. So there's so much to learn in terms of congenital heart disease and diagnosing and what the best treatment is. That's been the focus, but there is a shift. There's an increasing recognition that these other things are really important. There's obviously recently, the emphasis on diversity, equity, inclusion, access to care. I think those are all really important things, and our trainees are getting exposed to that some, but I don't think that we're there yet in terms of really educating the upcoming physicians and healthcare workers, let alone those of us who have been in the field for a while.
Yeah, thank you. I love this interaction here, Rylie and Dr. Bernstein, about, right, my child isn't a diagnosis and a set of labs and numbers. Tell me about them. When I would educate residents, when I would talk in my other role, anybody ever seen Dumb and Dumber? Yeah, there's a scene where he confesses his love, right? And he said, "What are my chances?" Does anybody remember that? And he's like 1 in 100, and she's like, more like 1 in a million. And he goes, "So you're saying there's a chance?" Right? And he's happy, and she's like, "Oh, he doesn't get it." But it's just indicative of, like, sometimes we have this information in front of us, and it's like, oh man, they don't understand. But to the family, it's like, I get it, and I have hope, and this is my child, and there's a chance. And so how do we work with that and do that? And I love that so much. Open it back up to the questions, thoughts, anybody? Yeah, oh yes.
I just want to thank Rylie for being here, right? I have the privilege of working in healthcare, but I also have the privilege of being a mom to a medically complex child. So hearing Dr. Bernstein and Dr. Tani talking about asking those questions is so vital. I had a 7-month NICU stay. I have a cardiac baby. So for me, I'm like, those resonate with me. To tie in what Nicole was saying, that opportunity, I think, comes down to what you guys were talking about. How do we create that culture within our systems, within our teams, within our outreach programs that says the patient and the family's voice is just as important as that evidence-based data? How do we carry that, and how do we message that? In addition to, how do we get those families to trust us, to allow us into that safe space, their safe space? Because, for example, when you go home at night and those alarms are still going off and you're really tired at 3 a.m. and you, in my case, I'm texting a friend, I'm going to lose it if I hear this alarm again tonight. Like, somebody, please. You're throwing out a lifeline. And as a parent, you don't want to feel like you're throwing out a lifeline. So how do we get those families to trust us? How do we support them and allow them to see what it really looks like at home? Because I don't know if this happens for Rylie, but we had one to everything. I mean, you got a system that can go wrong. We have that. So they're like, "Oh, you're in the ED. You were just in the ICU for 3 days. Here's an extra TPN line. Here's this. You're going to go home. Call us." And you're like, sure, sounds great. And you go home and you do it because it's your child and you love them. And there's a means to an end, right? But does that make sense? How do we get them to trust us to say, maybe we need an extra day here. Maybe we need a little bit more support at home. And I think it really does come down to that culture and building that trust. So
it's so interesting that you bring that up. I tell everybody that the people that I have the most connection with at the hospital are the people that spend time in our room. Orly, Jamie, Sharon, everybody from Rainbow Kids, they're that lifeline for us because Jamie and Orly and Sharon will sit in my room for 20 minutes getting to know me, getting to know Emmett, getting to know our family, our dynamic, how Jace thinks. I swear on my life, Jamie can read my mind. She walks in and she goes, I talked to your doctor and I know that Riley's going to tell me this and Jace is going to tell me completely opposite. And we go, yeah, but it's the people that sit down, that interact with Emmett, that are not in my room for 5 minutes to say, vitals are good, labs were good, this is good. You know what I mean? And it's shifting that culture to get the healthcare providers to understand that it's not us against them. It can't be us against them. It cannot. Because the only person that affects is my kid, and that's not happening. You get it. It's not going to be me against them because the only person, it's going to make me cry. The only person that suffers is Emmett. And I will not stand for that. That is not going to happen to my kid who doesn't understand. And so I think creating a culture where we can have doctors come in and say, what do you need? And I tell them, this is what I think, but I don't have the medical degree to do it. What do you think? Tell me your educated opinion. I'm going to tell you my mom gut opinion, and we're going to come to a compromise in a middle ground way where we can get Emmett the care he needs, where I'm being heard, but you're kind of stepping into my world a little bit. And I think it's hard because you get, fresh out of med school residents, and they're so eager. It's so great. They're so eager, but sometimes they're not eager to listen. And we've got to teach these people to sit down and say, tell me about your kid. How are they doing? That conversation right there, if I had had that conversation when Emmett was first born, everything in his first year of life would have been different. But I went home thinking my kid was going to die because that's all they said to me. There wasn't a relationship there where they could talk to me. There wasn't a relationship where they knew me at all. I can't even tell you the names of the doctors that diagnosed him, but I can tell you the names of every other doctor that we've had during hospital stays because they've gotten to know us. And it's shifting that idea that, we're doctors, and this is not meant to offend anybody, but it's shifting that mentality of the doctors hold all the knowledge and I have to learn from them. It's learning together. It's changing this culture into how do we, as people without a medical degree, but a lot of knowledge, partner up with the people that have the medical degree and also a lot of knowledge to come together for my kid, not for the diagnosis. Because if you look at Emmett on paper, and I'm sure it's the same with your kid, if you look at them on paper, they're goners. Nobody's going to believe in a kid that's got like 28 specialists, over 100 active diagnoses. You know what I mean? Like 25 meds a day. Everybody's going to look at him and be like, no, give him 6 months. And I look at him and I'm like, I can understand everything that kid tells me. You know what I mean? He may not be able to talk, but dang, is he loud. He's opinionated. He knows what he wants. He does not like his little sister. You know what I mean? Like, there's a kid there, you guys. And getting them to understand that we know the kid and they've got the medical background to help us achieve what we need done, that's everything. I don't know how to do it. That's the whole point. I don't know how to do that. But that's the goal. That's the end goal right there.
Rylie, I'm going to push back a little bit on that because you said...
Oh, no. Here we go.
You said...
Welcome to every hospital stay we've had.
This is me and her in the room. You said it's Emmett that suffers, and the point of this is a family-centered care conference. You suffer too.
Well, yeah,
Jay
that's the
suffers
point.
too.
If Emmett goes through it, I mean, how do you as a mom not go through it?
Right.
Jace is learning that you as a dad, you go through it. He's understanding I'm not at the hospital all day, every day, but I'm calling him everything that happens. Hey, the port won't draw back. Hey, we just lost a line. Hey, we're starting TPN. We can't get back onto full feeds. Jace is starting to understand that that's an emotional hit every time that phone rings. And you're right. Emmett is the one that suffers, but like, there's no way, there's no physical, mental, spiritual, whatever emotional way that the parents and the siblings don't feel it. And that's what I'm slowly starting to learn with Bryn, is that it'll trickle down even to a 9-month-old.
Yeah. And I also want to emphasize that point too of, on paper, right? Hey, nonverbal, developmentally delayed, have all
Right.
these things. And I can't tell you in the 15 years, the thousands of experience I've had of parents will be in a room and they're like, hang on, you see that eye twitch right there? He does not like what is on TV right now. So I got to, and they'll sit there and just be like, okay.
All
Good, he likes
day.
Right? They expert.
Right.
You know and read your children. Anybody here who has children can know and read their kids better than anybody else. So honor that.
I think part of it is also getting healthcare workers to understand we don't like to be there. If I'm telling you that I think my child needs another couple days in the hospital, I am doing it through gritted teeth because I want to sleep in my own bed. I can't tell you how many people have come up to us and said, you guys just seem like you love to be here. And I'm like, there's the door. Thank you for your help. Thank you for coming. I appreciate you. Right there.
Much more gracious than most. Yeah.
It took a lot of coaching to get there. It wasn't that nice at first, let me tell you. No, but I think it's really, helping these doctors and these nurses and these providers understand it's not fun for us. It's really not. I would really like to sit on my own couch and sleep in my own bed and eat my own food and have control over that. But if I'm telling you that Emmett needs to be here for a few more days, there's something going on. And it's not this, let's just mooch off of this system and sit here. You know what I mean? Like it's not fun to be stuck in a room all day trying to entertain a very opinionated, almost 6-year-old. And so getting the shift of mentality to these parents don't want to be here any longer than they have to be. But if they're saying they need to stay, then we need to figure out why and investigate how to make them comfortable. Maybe it's just a fear of, I'm going home with a new machine and I don't know what to do and nobody's explained it to me. And so we got to stay till I can feel like I can run this thing you gave me. We're staying. And maybe it's a simple conversation that says, this is how you work it. This is what's happening. Or maybe it's something, we've had a couple of instances where it's, hey, by the way, you were about to send us home with pneumonia, and the mom got kicked in. Things like that. Just getting them to understand that we like to be at home. And staying longer is not what anybody wants. But sometimes it's what's needed to take care of a kid. Don't know if that made sense, but she's nodding. She gets me.
And I love also to kind of throw back to what Nicole said when she first talked kind of about the effect on caregivers too. It was in relation to the pandemic, but talking about bearing witness to suffering of your own child and those around you. Caregivers experience that too, bearing witness to suffering. And how do we as people kind of be okay with us to go into that space and say, I'm here with you in this moment. So yeah, thank you. Thoughts, questions? We have 5 minutes. Sir.
Thanks. My question is, how do we help families get help when they're home in the community to support them? What's lacking? Because I get, like, with a medically complex child, I don't know how to run those machines. I don't know how to respond, right? But if I'm your neighbor, if I'm your, right, someone in your community, how can I support you and how can I help you get that support, ask for that support, be vulnerable to get what you need to be supported in the community, be successful there?
That is an incredible question. I think it comes in parts. The biggest support to a medically complex mom is being able to answer your questions honestly. How are you doing? I'm tired. How did you sleep last night? I didn't. You know what I mean? And getting into that space where you can be the person that's comfortable with the uncomfortable answers. That's the number one thing. That right there would open the door to any other support and resources, because I know the resources. You don't. I do, because I've been learning for 5 years or 15 years or however old my child is. But it comes with being a part of the medically complex world. And you have to become somebody that I can sit down and say, I'm really struggling and I know that this can help me, but I'm too overwhelmed to do the application. And then you say, hey, this is a group or a nonprofit that I can look into more. And you can say, yeah, I can help you with this application. Let me help you do that. But at the same time, they're giving you hints as to these places and these people and these things that can help them. And I know it's not, the answer you want to hear. There's not like a list printed out that you can hand somebody. But if you can get to a point where you can be the person that's comfortable with the uncomfortable answers, I'm going to tell you exactly what I need. I'm going to tell you, I've got to pick up formula from Utah Kids Foundation, but it's 20 minutes away and I don't think I can put Emmett in the car because he's having a lot of seizures. And you say, oh, what's Utah Kids Foundation? Oh, it's just a nonprofit organization in Utah that, helps provide medical supplies and support to families for free. And you say, oh, I didn't know that. And now you can lock that away in your brain, but it really just comes from getting comfortable with these families and getting to know them, and then saying, what are some resources about your child? Can you teach me more about Down syndrome? Can you teach me more about cleft palates? And they are going to give you a whole list of, read this brochure, read this website. Most families have like a printout ready to go that is all about their kid, all about the disorder, and like national and public and local resources that can direct you. And so I really, really, really wholeheartedly believe that a lot of people are looking for like a pamphlet that I can say, hey, look, like these are local to Utah, but it's really connecting with your parents, asking them that dang question. She's got it down. Asking them that question, tell me about your kid. Tell me about Emmett. Tell me about so-and-so. Tell me about Emmett's disorder and where I can learn more about how to support you. I don't know if that's helpful. I don't know if that's the answer you're looking for. I think the next, breaking that down again, the next part would be, there are some really, really good places to start here in Utah. Utah Kids Foundation is massively underrated. They are a 501c3 here in Utah, and they take in donations and then spread that throughout the state to families whose insurance won't cover it, who can't afford to buy it, who don't have access to, DMEs or durable medical equipment supply companies that carry such things. They sell and resell things extremely cheap, so families have access to the supplies and the care and the diapers, and people will donate wheelchairs and walkers and sleep safe beds. They're huge and massively underrated, and I think they're a fantastic place to start. Reaching out to Utah Kids Foundation and saying, hey, I met Rylie, and they're gonna be like, oh yeah. But tell them, say, where can you direct me? Where can I get these local resources to start passing along to my family? And they'll set you right up. But I really, really, truly believe that if you want to know the correct places to go, start getting comfortable with families, get comfortable with the uncomfortable answers, and then they'll open up to you and say, this is where you can learn more. This is the charity that helps us the most. These kinds of people can do that.
Sit in uncomfortability.
Yes, exactly.
Yeah.
Exactly. I think if anybody else, just off the top of my head, is looking for other resources, Children in the Earth and Angel's Hands Foundation are amazing, amazing places to start. Utah Kids Foundation, Children in the Earth, Angel's Hands Foundation. All of them are incredible. All of them are registered nonprofits. All of them do massive fundraising to fly families to different hospitals. They cover medical expenses and things like that insurance won't cover. So I think if you're looking for a generalized, what can I pass along to my patients, those three would be your go-to. And then ask them how they're doing.
I want to pick out something you said there too about like, hey, Medicaid or these forms that they say, hey, fill this out, do these things. I've had the privilege of being adjunct faculty at the college here for many years, and in a medical social work class, I've handed out Medicaid applications to that group of students and said, fill that out. Master's level, bright, prepared students go, what do I, and I go, now imagine you have medically
pay money
complex
to
kids.
see
And
that.
remember you have, now how do you, and I have some colleagues in this room who recognize that and go, let me take that for you.
Right.
And I want to add, to speak to my caregiver people too, when you have a unit full of families that need that help too as well, like it's, how do we
do it? Yeah.
do that as well? How do we help you? How do we help others? But yeah, I'll shout out my social work colleagues. Yeah.
Well, and even just going along with that, Orly, I think it's just having the courage to walk up to somebody and say, I don't know if you qualify, but have you heard of Medicaid? Have you heard of SSI? Have you heard, you know what I mean? Like us medically complex parents, it takes a lot to offend us. So I guarantee you, if you're scared you're going to offend us, you're not. We've heard it all. You're not even going to come close to like the top 20. You know what I mean? You're fine. Don't even worry, I think, about approaching a family. But in our situation, Rainbow Kids saved our life, literally. And I credit them with a lot emotionally, but at the same time, financially. They saved our family. I was sitting at a Rainbow Kids lunch before COVID, and Sharon comes up to me and she says, you need to fill this out. And she literally just slides this piece of paper across to me. And I'm like, yes, ma'am. Because I trust her. I know her. I don't care what it is. If Sharon says I need it, then we'll figure it out later. I'll fill it out. Yeah, I need it. Sharon knows better than I do what I need at this point. Okay, and so I filled out this application. 2 months later, I get a call, and they tell me that Emmett qualified for the medically complex children's waiver, which puts him onto state Medicaid, and it does not count mine or my husband's assets, which means Emmett will get Medicaid for the rest of his life because he's not making any money. Jason and I have calculated, we're a little bit twisted. This is the fun game that we play, okay? We get itemized statements in the mail, and we go, okay, it's a 2-night hospital stay. And he goes, primary children's or Utah Valley? And I say, primary children's. And he said, did we do any scans, anything? And I say, no. We were just there overnight, and we guess how much our hospital bill is. But we did this thing for a long time where we started adding it up, and I stopped at $4.5 million. And Emmett was 3.5 years old. If they had not walked up to me and slid that paper across, we'd be looking at millions of dollars in medical debt. Jace quit his job in 2019 to keep us below the poverty level so that we could keep our Medicaid. We lived off of a $7,000 tax return for 10 and a half months. But because they walked up to me and said, you need this, who cares if I get offended? I mean, even if I was mad or like, oh, they think we're poor, who cares? Because now I look back and I've got another child I have to take care of. I have family obligations that need to be met. My husband needs to work to provide for us. Learn the resources and just start mass handing them out. People that need them will get them. People that don't need them will look at the paper and throw it in the recycling bin.
Right. You don't know what you don't know.
Exactly.
And so you depend on the experts to know the resources.
Exactly.